Good morning, participants and dear speakers and the moderators. We shall start our 13th webinar of International Series of Webinars. Good morning, everyone. Greetings from Yenapoya, deemed to be University, Mangalore, India. In continuation of International Series of Webinars, on behalf of Yenapoya Physiotherapy College, I am Dr. Mudassir, Assistant Professor, Yenapoya Physiotherapy College and Coordinator for this International Series of Webinars. I cordially welcome you all for our 12th webinar today. We are pleased and honored to have Vice Dean of Yenapoya Dental College, Yenapoya deemed to be University and Senior Professor Dr. Lakshmikant Chhatra sir today with us. I welcome you, sir. Thank you for joining us, sir.
Thank you.
I thank all my colleagues, senior faculty members from various constituent colleges of Yenapoya deemed to be university, and faculties and students from various dental and physiotherapy colleges across India for joining us. Today's topic is on Trismus. Trismus will be presented by the Oral Medicine and Radiology Department, Yenapoya Dental College of Yenapoya deemed to be university. And I'm again honored to have Dr. Lakshmikant Chhatra, Vice Principal, Yenapoya Dental College, Sir is Senior Professor in Oral Medicine and Radiology as a first speaker to grace today's webinar. And I'm glad to have Dr. Sajjad Butts, Faculty and PhD Scholar from Oral Medicine and Radiology, Yenapoya Dental College as our second speaker. I welcome Dr. Chhatra sir and Dr. Sajjad Butts. Thank you for accepting our invitation. Before we start, I take privilege to introduce our moderators of this session. Dr. Varsha Upadhyaya. She is a reader from Department of Oral and Maxillofacial Surgery, Yenapoya Dental College. Dr. Varsha is affiliated to Yenapoya Dental College since 2013, and presently she is pursuing her PhD. Her area of interest is temporomandibular joint disorders and maxillofacial trauma. Dr. Varsha has many publications in both national and international scientific journals to her credit. I thank Dr. Varsha for accepting our invitation to moderate this session. My second moderator of this session is my colleague, Dr. Shivakumar, who is currently working as an associate professor from Yenapoya deemed to be university. Sir has got total teaching experience of 12 years, and Sir has completed his Masters in Physiotherapy in Cardiorespiratory Disorders and Intensive Care. I am highly thankful for you, sir, for joining me here and accepting my invitation. Before we start, there is just housekeeping before we start our session. If you have any questions during the presentation, I request the participants, please type them into the chat box and we will bring your questions at the end of the presentation. And meantime, I request the participants to mute their mics. Mr. Abdul Malik, kindly mute their mics. Abdul, yes, thank you so much. Yes, I again repeat, if participants have any questions, kindly post them into the chat box and we will bring them up into the session after the presentation. Now, without any further ado, I request our moderator, Dr. Shivakumar, Associate Professor from Yenapoya Physiotherapy College, to highlight the credibility and expertise of our speakers. Over to you, sir.
Thank you, Mudassir. It's a pleasure to introduce Dr. Lakshmikant Chhatra, the Senior Professor and Vice Principal, Yenapoya Dental College of Yenapoya deemed to be University, Mangalore. Dr. Chhatra has completed his Bachelor of Science from Mangalore University, Karnataka, and also had a Diploma in Pharmacy from National Institute of Pharmacy, Shimoga, Karnataka. Then he went on to do his BDS and MDS in Oral Medicine and Radiology from Mangalore University, Karnataka. Dr. Chhatra has more than 25 years of teaching experience, and he started his academic career as assistant professor in College of dental surgery, KMC Manipal, and later joined Yanapaya Dental College, Yanapaya deemed to be university, and currently holds the post of senior professor and head of the department, oral medicine and radiology department, 15 years. Sir has recently taken charge as the vice principal of Yanapaya Dental College, and also his publications and books runs to pages and pages and pages. So I'll just mention the numbers rather than all the topics. Sir has more than 200 publications in both national and international scientific journals, not just in any journal, but journals of repute. And also is authored more than 12 books. And Sir is also presented in more than 20 scientific conferences, and also innumerable guest lecture to his credit. And Sir has also been a subject expert for Manipal, Maya University, Manipal, Calicut University, Calicut, D.Y. Patil University, Mumbai, Nitya University, Mangalore, and also National Board of Examination, New Delhi. And during his long and prestigious career, Sir has held positions of importance and also leadership roles. Sir became a IAOMR life member since 1994 and ideal life member Dakshina Kannada branch since 1997 and founder member of Orofacial Genetics since 1999 and member of Indian Society for Dental Research since 1998. He has also served as president of the IDA, that is Indian Dental Association, Dakshina Kannada branch during 2003 and 4 before and also has worked as vice president of IDA DK branch during 2002 and 2003 tenure. And he has also acted as chairman registration committee of 10th National Conference of Indian Association of OMR and also acted as a convener of 8th ISDR conference. Sir's credibilities and Sir's experience and expertise runs into pages, and it's been a privilege and pleasure to introduce you, sir. Thank you for accepting our invitation. Next, I would like to introduce our second speaker, Dr. Sajjad Ahmad Bush. Is currently a senior lecturer and PhD scholar, Department of Oral Medicine and Radiology, Yanapaya Dental College. Dr. Sajjad has completed his BDS from MRA Dental College, Bangalore, Karnataka, and then went on to do MBS in Oral Medicine and Radiology from Nitya University, Bangalore, Karnataka. Currently, Dr. Sajjad is currently working as faculty and PhD scholar in the Department of Oral Medicine and Radiology in Yanapaya Dental College, Yanapaya. Before that, Dr. Sajjad has worked for Ministry of Health, Kingdom of Saudi Arabia for 7 years. And he has more than 20 national and international publications. Dr. Sajjad is also as an ambassador of Bentham Science Publisher and also reviews scientific articles for various journals, including Kamuriyat Dental Journal, Journal of Oral and Maxillofacial Radiology, and also case reports in orthopedic research. Dr. Sajjad's research interests include non-invasive salivary biomarkers in oral cancer, oral pre-cancer, and salivary proteomics. I welcome you also, Dr. Sajjad. Thank you.
Thank you, sir. Thank you so much, sir. I request Dr. Varsha to welcome our speakers before our speakers start the session. Over to you, Dr. Varsha.
Thank you, Dr. Mudassir. A very good morning to all. At the outset, I would like to thank the principal of Yanapoya Physiotherapy College, Professor S. Padmakumar sir, and Dr. Mudassir Rashid, Assistant Professor YPC, for organizing a webinar series of this magnitude and inviting me to moderate this session. I welcome our first speaker for the day, Dr. Lakshmikant Chatra sir, the Vice Dean, Yanapoya Dental College, and Professor, Department of Oral Medicine and Radiology, who will be speaking to us on the topic of trismus. Over to you, sir.
Thank you. Good morning, everybody.
Good morning, sir.
Good, good morning. Hello. Can you hear me?
Yes, sir.
Yes,
You're
sir, we
audible.
can hear you. Go ahead, sir.
Hello.
Yes, sir. You're audible, sir.
Fine. Can you see my slide?
No, sir. We are not able to see the slides.
All right. All right. Okay. Good morning, everybody. Yeah. Now,
No, sir. Slides are not visible, sir. Sir, probably you can log out and log in again, sir.
Yeah, we're trying that.
coming.
Yes, sir, we can see the slides now, sir.
Sir, your mic is muted, sir. Sir, we cannot hear you, sir.
Can you hear me now?
Yes, sir.
Hello? Yeah, okay. Shall I start again?
Yes, sir, please.
Yes. Yes, sir. Good morning, ladies and gentlemen, those who are presenting, those who are there today. I'm presenting this presentation is coming from the Yanapai Dental College of Yanapai University, situated at 10 kilometers from Mangalore in a lush greenfield campus. I am honored and privileged to be the part of this international webinar series conducted by the Yanapai Physiotherapy College of years. At the same time, I thank my today's webinar. Let us move on to the topic today, Trismus. Trismus is derived from the Greek word trismus, that means snatching, is that when you're holding the upper or describe the trismus, it may be as the ankylosis, locked jaw, restricted mouth opening, and so on and so forth. But according to the medical terminologists, the trismus means movement of the part, any difficulty in movement of any part of the body due to muscular spasm. If a difficulty in opening of the mouth or any part of the body because of the trauma or stabilization, we may not call that as a trismus. By definition, if there is any muscular spasm, then only call as a trismus. So in a head and neck region, trismus always being referred as locked jaw, difficulty in opening the mouth, or sometimes you say that patient cannot be able to open the mouth at all. There are certain conditions wherein there is muscular spasm is not involved, still there is a difficulty in opening the mouth. The conditions like the precancerous condition like oral submucous fibrosis, wherein fibrosis leading to a difficulty in opening the mouth, there is no muscular spasm at all. To say mouth opening is restricted, one must know what is a normal mouth opening. The various study has been done across the globe. The normal range of mouth opening is 40 to 60 millimeter, lower limit being the 35 millimeters. We have done a study in our department wherein Dr. Shaul Hamid has done a study in our department to see the normal opening of the mouth in our population out here. We found that it is 35 to 47 millimeters, but it is more in in our population, it is more seen in the females than in the male. That is 47 millimeter, whereas male had a 40 millimeter mouth opening. Whereas the the literature survey shows the upper limit is up to 60, as more commonly seen, more mouth opening are seen in the male population. To say the mouth opening is restricted or a trismus, one should be able to make out there are some must be guiding points. When you say between the 20 and 30 millimeter mouth opening is there, it is referred as mild restricted mouth opening. Between 10 and 20 millimeter mouth opening intraincisally, it's been referred as a moderate mouth opening. Below 10 millimeter intraincisal mouth opening being referred as severe restricted mouth opening. Based on this, the treatment can be followed up. The trismus may be the most of the time, as I mentioned earlier as well, that it could be a spasm of the muscle. You know that the jaw movement has taken place because of the masticatory muscles, either opening of the jaw or closing of the jaw. Masticatory muscle is involved in the opening and closing and all the masticatory movements. Whenever there is a motor disturbance in any of these nerves can cause spasm of the muscle leading to a difficulty in mouth opening. Trismus may be a temporary. It lasts for 2 weeks. That means exactly 15 days time or less than that. If it is more than a 16 days, 15 days time, we call it as a persistent trismus. Or as other classification, it could be a simple or it could be a life-threatening. This trismus can interfere with the normal speech, eating, including ability to swallow, and it may maybe because of the iatrogenic causes due to the dental setup. The etiology of the trismus. Just a minute. It could be a traumatic, inflammatory, infectious, congenital, head and neck neoplasms or patient undergoing radiotherapy. It could be iatrogenic, doctor-induced. It could be neurogenic, or it could be a psychogenic. When you're talking about the infections, the first most common cause of infections can lead into a trismus. Especially, it could be an odontogenic infection arising from the teeth or associated structures, or it could be from the non-odontogenic structures like tonsillitis, tetanus, meningitis, or brain abscess or a parotid abscess. Most common, the trismus, what we come across in a day-to-day is that infection from the dental origin. It's called as odontogenic infections. If it's unchecked, may go in for the cellulitis and severe and leading to a total trismus. Second most common cause could be the trauma. It could be a road traffic accidents, or it could be an administration of a general anesthesia, or it could be a sports injury, or a difficult dental procedures which is taking quite a long period. Treatment required a lengthy appointment in mandibular joint disorder as such. It could be intra-articular disorders or extra-articular disorders. Intra-articular associated with the temporomandibular joint itself, or it could be from the outside. It could be an anterior disc displacement with reduction or without reduction, or it could be an ankylosis of the joint. It could be bony ankylosis or the fibrous ankylosis. Earlier to the 2000, there used to be a lot of cases of the ankylosis due to forceps delivery during the delivery period. It may lead into the fusion of the condyle head to the cranium. Very difficult to open the mouth. Patient will have a difficulty in chewing, and patient will have the reduced growth and development of the mandible. Temporomandibular joint disorder could be an extra-articular. It may be an infection from the odontogenic infection. It could be from the soft tissue infection. It could be from the foreign body reaction, like in the road traffic accidents. Or it could be from the as simple as the tooth most could be the common cause for the trismus. They say that when the unexplained, the trismus could be causative agent for the underlying disorders like neoplasia. So malignant disorders of the head and neck region, either involving the mandible, maxilla, or an associated structures like tongue, tonsils, and the base of the tongue can cause the trismus in a long run. There are certain conditions in which the trismus is due to, or restricted mouth opening is due to a precancerous lesion or a condition like oral submucous fibrosis. Oral submucous fibrosis is a precancerous condition generally seen in a geographic area like India or Indians staying abroad due to areca nut or betel nut chewing habits in a long run, leading to a fibrosis of the subcutaneous tissues, leading to a decreased mouth opening. There is no spasm of the muscle as such, but there is a decreased mouth opening due to the formation of the vertical band on the buccal mucosa and the retromolar trigone. Next most common cause could be the radiotherapy and the chemotherapy. The patient underwent radiotherapy for the head and neck, the neoplasia could be the cause for the restricted mouth opening. Restricted mouth opening due to the path of the radiotherapy, where the muscles are involved, inflammation of the muscle takes place in the beginning, followed by a fibrosis and leading to the restricted mouth opening. This restricted mouth opening would be a temporary. As soon as the treatment is completed, it may come back to the normal within 5 to 6 months' time with the help of the physiotherapy. Chemotherapy also plays a help in the formation of the trismus. It's basically because of the formation of the stomatitis in the oral cavity. Because of the stomatitis, the patient cannot be able to open the mouth because of the pain. There are congenital, the anomalies can lead into a restricted mouth opening. One among them is the coronal process enlargement. You can see it in the picture out here in the panoramic radiograph on the top, as well as the CBCT image of the three-dimensional image. You can able to see the arrow shows the enlargement of the coronal process. On closing the mouth, it may hamper the movement of the coronal process. It is rubbing against the anterior medial margin of the zygomatic arch, leading to a restricted mouth opening. There are some iatrogenic causes, doctor-induced causes for the trismus as well. Prolonged treatment time taking for the root canal treatments or multiple root canal treatment in one sitting could cause a difficulty in opening the mouth. That is due to a stretching of the muscle for the longer period of time, wherein your Starling's law come into the picture. Contraction of the muscle is directly proportional to the muscle in a physiological limits. So if you stretch the muscle beyond the physiological limit, following which there will be a forceful contraction. This is what we call it as a iatrogenic trismus. And in other cases wherein the local anesthesia being introduced into the body, when you inserting the local anesthetic, especially the inferior alveolar nerve block, you may be hampering the few fibers of the medial pterygoid. This leads into a trismus in a long run. The drugs that have been given, succinylcholine, phenothiazines, and tricyclic antidepressants have been known to cause the trismus. There are some miscellaneous conditions at which it may cause the trismus is hysteria. Hysteria is an emotional conflict is converted onto a physical symptoms, thus releasing the patients from the emotional conflict. This onset of the hysteria usually under the age of 35, more commonly seen in the females. It has been suggested that it's more commonly seen in people with parent-dependent personality. So they have a varied the features as such. They may have a combined with a paralysis, trismus, blindness, anesthesia, or anorexia and vomiting. These particular features are not related to this as such. When you're looking at in our practice as such, when the kid comes over to the dental treatment, as soon as the kid wanted to get the treatment done by the dentist, and immediately the patient will go in for the hysteria. It is basically the extreme emotions or apprehension that lead into a trismus. This is typically called as hysteria. When you take the hysteria and electromyographic study, it shows the little or no activity of the lateral pterygoid, there is an increased activity of the medial pterygoid, masseter, and the temporalis. This activity usually seen in normal biting. So why this particular thing is happening? Basically because of the apprehension. The other causes of the trismuses are multiple sclerosis, scleroderma, total palsy, lupus erythematosus, oral submucosal, so on and so forth. There are so many causes which may cause the trismus as such. Once you understand the etiology for the trismus, one should be able to know what are the signs and symptoms you're looking in for in trismus conditions. As you know, it's an extremely painful condition. At times, is life-threatening as well. If there is an infection leading into the periapical abscess or a dental abscess that leads into the space infection, can lead into life-threatening because of the subarachnoid edema formation. Prolonged popping and grating of the joints. At times, patient may have a fever because of the infection. Limited movement of the jaw and radiating pain to the head and neck regions. The patient may suffer from the headache, earache, and fever. It could be a referred pain. Some secondary symptoms includes difficulty in mastication, swallowing, breathing, speech impairment, limited jaw movement that leads to malnourishment because of the patient cannot be able to eat, difficulty in consuming the nutritious and healthy food, and preventing the chewing. And there may be a restricted movement in the jaw, does not provide a room for the mastication and for the tongue to help in swallowing. Patient may have a difficulty in speech and certain pronunciation of the pertinent words cannot be able to make, that leading into a slurred speech and discomfort. Common side effect being the poor oral hygiene. Patient cannot be able to brush their teeth, rinse the mouth, floss because of the limited mouth opening. In some cancer patients, those who receive a radiation therapy for the cancer, that may have a very poor oral hygiene they are higher risk of developing xerostomia and temporomandibular joint and the mucositis that leads to a pain and trismus. So what are the long-term effect on the patient on the health-related quality life? Usually patients with trismus, regardless of how it was acquired, reportedly to have significantly higher discomfort. Trismus overall affects the person's health in terms of difficulty in mastication, swallowing, breathing, speech, and other criteria. Patient may experience a difficulty in working and the family life. The complication of trismus may come other factor in terms of social, economic, family disparities that the patient may experience. Amount of pain the patient suffers is another factor affecting the mental health of the patient in a long run. Depression, anxiety, and insomnia are often associated with the trismus can affect the individual's social, work, and family life. Once you understand these are the symptoms, it may be a classical symptoms of the trismus, one should be able to get diagnosis, how diagnosis can be made. But here are some flow chart, you can able to look at it in your screen. If it is an acute, it could be come from an acute infection from the head and neck region. If it is no, it could be a neoplasm of the head and neck region. If it is no again, it could be, you have to think in terms of the precancerous lesions like oral submucous fibrosis, scleroderma, or the TMT pathology directly. Or if it is yes, it is from the acute lesion, from the head and neck region, yes, then you're considering patient may be having a primary tumor, carcinoma, or could be a secondary carcinoma into the jaw bones, or third, it could be a patient underwent treatment for the radiation therapy, or it could be a complication of a radiotherapy, or it could be a tumor recurrence. If it is a head and neck associated acute pain, acute trismus, yes, then you consider the odontogenic infection like pericoronitis, odontogenic ear, or the space infection that leads into a acute trismus. If it acute trismus is yes, then it could be a recent history of trauma anywhere in the orofacial region. If yes, then you look in for a head and neck trauma. If it yes, then it have to go in for either the fracture of the temporomandibular joint, zygoma, mandible, or any part of the orofacial region. It could be a leaf foot 1, 2, or 3 fracture of the midfacial skeleton that can lead into a trismus. If it is no, then we consider the tetanus, the Clostridium tetani infection, or could be a drug reactions. This how the diagnosis can be made. Since the trismus is a multifactorial disease, one can able to rule out each and everything, starting with the commonest lesion, go up to the rarest lesion. Now, briefly on the treatment, Sajad is going to tell much about the treatment part of the trismus. Then I'm going to talk something about the treatment. Treatment of a trismus should be directed in eliminating the cause. First, diagnosis assessment will be made to any type of a therapy should be applied only after the elimination of a cause is taken place. Once the elimination of the cause is carried out, then non-steroidal anti-inflammatory drug as well as by giving a physiotherapy can reduce the trismus to some extent. In cases of those a simple trismus, those who complicated trismus requires the physiotherapy for a long period of time. In a significant conditions cases or the primary trismus can be treated with the underlying cause can be elevated, removed, and by giving a non-steroidal anti-inflammatory drug should suffice. Patient will come back to the normal condition within the stipulated period of time. However, physiotherapy does play a role in a case of those it is not complacent to the regular treatment. In concluding my presentation, I would say trismus is best addressed by identifying the inciting etiology and directing the treatment towards the underlying cause. Refractory cases may require physiotherapy interventions in the long run. Thank you, ladies and gentlemen.
Thank you, sir.
Thank you,
You're
sir.
welcome.
I would like to briefly summarize the lecture.
That is later. Sujat has to take it.
We'll go to the summary at the end of both the sessions. I would like to invite our second speaker for the day, Dr. Sajjad Bach. He is a PhD scholar and a lecturer in the Department of Oral Medicine and Radiology. He will be presenting to us on the management of radiation-induced trismus. Over to you, Dr. Sajjad.
Thank you very much, Dr. Varsha. I am highly thankful to Principal Yanapoya Physiotherapy College, Professor S. Padmakumar sir, for having chosen our department from Dental College to speak about this topic, that is trismus. Although it's a very vast topic and definitely it cannot be covered in one setting, but our dynamic vice principal, Professor Dr. Lakshmikant Chhatra, I would like to, am I audible?
Yes.
Your voice is breaking,
All right.
sir.
Directly to the
So the voice is still breaking and sometimes not audible at all.
It's not working. I think I should. Okay. No issues.
Sir, now you are audible.
Sorry for the inconvenience. Can you hear me now, sir? Is it audible?
Yes, sir. Go ahead, sir. Yes, it's audible. It's audible. Go ahead, sir.
Oh, okay. All right. Okay. Let me go directly to the presentation now. Can you see the PPT, sir?
Yes, sir. You can see it. Go ahead, sir. Sir, we can see the PPT now. Please go ahead.
All right. Okay. As I said, it's a very vast topic, trismus, and it's very difficult to complete it in one.
We cannot
Your
hear
voice-
you, Dr.
Your
Sajjad.
voice is again breaking.
All right. So I have chosen one of the components of the management of trismus, which is very important, keeping in mind both the dental and physiotherapy attendees. So the topic for this I have chosen is radiation-induced trismus and how to manage and how what is there in the literature about the various aspects how radiation-induced trismus is managed. So coming to the very basic definition, actually, there has always been a controversy actually to how to define trismus. What measurement will be considered as trismus And different authors and different researchers had different opinions about the range of mouth opening and when to call it as trismus. So some authors used to call greater than 30 mild, between 20 and 30, sorry, moderate trismus, and below 10 millimeters as severe trismus. Then, according to this, conducted a study wherein he reined in head and neck cancer patients and he worked upon them and to see what all functional cutoff is there in such particular patients. Functional cutoff means at what cutoff the patient's quality of life gets decreased, and at what cutoff level above that the patients enjoy a good degree of quality of life. So this has been standardized since that time, and particularly it applies to the topic which I am giving today, that is radiation-induced trismus. So in head and neck carcinoma, this particular measurement that is either less than or equal to 35 millimeters, mouth opening from incisal edge of the upper anteriors to the incisal edge of the lower anteriors is considered as trismus, if it is less than or equal to 35 millimeters. Now, as Sir spoke about various etiological factors, so when it comes to the treatment, definitely the underlying etiological factor has to be sorted out before any kind of treatment is to be instituted. So that means all kinds of trismus, whenever approaches to any department, so they do not necessarily follow a uniform pattern of treatment until and unless a definite differential diagnosis has been made. So there are certain situations, like I have mentioned there in case of acute trauma and tetanus, where trismus develops in an acute manner. Most of the rest of the reasons, it deciphers slowly. The trismus gradually develops over the period of time. And the basic diagnostic mechanism for trismus is actually a 3-finger test, which Sir has already described in his presentation. So what is important when any kind of trismus approaches for treatment? It is a must to undertake the differential diagnosis before any kind of treatment is instituted in case of trismus. Now, most of the cases of trismus are self-limiting. They are transient and they resolve within 2 weeks of time. And as we all know that a little bit of discomfort undergoing a dental extraction, the local anesthesia, no blocks, it has to be there for around a couple of days during routine patient life. Now, the interventions depend upon what kind of discomfort and what is the degree of this discomfort and how far it affects the patient's dysfunction. So usually during routine dental procedures, which in fact involve the invasive procedures of local anesthesia and surgical procedures, usually upon taking of care of post-operative instructions, the symptoms usually remain mild. So when a patient reports mild pain and dysfunction, an interim practitioner, what he can do is prescribe these following therapies, which I have mentioned: heat, analgesics, soft diet, and if necessary, then muscle relaxants can also be instituted. Now, what does heat therapy do and how is it advocated? So moist hot towels on the affected area for 15 to 20 minutes every hour. It has got its effect on the circulation. Aspirin is usually adequate in managing the pain associated with trismus, and its anti-inflammatory properties are also beneficial on top of its analgesic qualities. Now, as I mentioned earlier, muscle relaxants, in case the need arises, we can institute or we can advise diazepam 2.5 to 5 milligrams 3 times daily. Now, when the acute phase of this trismus is over and patient still has some kind of symptoms, then in that case, we have to undertake or we have to think of any physiotherapeutic interventions, which can involve opening and closing of the jaws and to perform lateral excursions of the mandible for 5 minutes every 3 to 4 hours. The simplest way of attaining lateral excursions of the mandible involves chewing of sugarless gum, as I have mentioned here. Now, further dental treatment in such a situation, when a person has undergone any kind of treatment and is facing symptoms of trismus, have to be avoided. Otherwise, it is going to add on to already complicated situation. In some situations or cases, when there's a need to undergo treatment, as particularly in case of an acutely painful infected tooth, then in that case, we have the provision of advocating the local anesthesia in a closed mouth approach as well. So there is no need to open the mouth. Usually, when we undertake simple procedures like dental extraction or root canal treatment, we give local anesthesia in a wide open mouth position. It has got its own advocates. And in this particular situation, we have this provision of giving an anesthesia in closed mouth position also. What that will do, it will permit a patient to open, and it will allow practitioner to provide the appropriate treatment to that particular patient who is already in distress because of the underlying trismus. Now, when these protocol is followed, most of the cases of such kind of trismus, patients report improvement within 48 hours. Of course, although therapy should be continued until the patient is free of symptoms. Now, the time comes when pain and dysfunction continue unabated for more than 48 hours. So there is a chance that such kind of patient, he is facing from an infection. So in that particular case, we have to institute antibiotics. We have to give antibiotics. There's a proper regime on basis of the cases, and it can be given till 7 days. If no further improvement within 2 to 3 days, which I mentioned earlier how to tackle it, without antibiotics, or 5 to 7 days with antibiotics, or if the ability becomes less to open the mouth, then in that case, the patient has to be referred for a specialist, to a specialist. This is the one more treatment aspect of trismus when the surgery is instituted. So in case of temporomandibular pathosis like intracapsular disorders, or when bony inferences are there, as sir had put one slide, if I'm not wrong, bony inferences from either styloid process or coronoid process, they can also result in limited mouth opening. When else a surgery is to be instituted? Of course, when you have a foreign body or restrictive maxillomandibular bands of dense scar tissue. There are plenty number of cases of foreign body interventions that have resulted in trismus. A simple example, I came across a case report recently of a young adult who was undergoing orthodontic treatment. So while adjusting for the braces, the orthodontist usually cuts the end of the wires, and one of the wire had gone, it had dislodged in the posterior aspect of the mouth somewhere, and that also resulted in trismus. So that is the case when can a foreign body initiate trismus, although there are other possible causes as well. Now, treatment always should be directed towards the cause of etiology. Now, this is the topic actually I wanted to focus today, as we have attendees from both the specialities, that is physiotherapy as well as the dental. This is cancer, trismus, and physical therapy. Physical therapists are professionals who examine, diagnose, and manage conditions that limit body's ability to move. Now, they are obviously uniquely qualified to assist with the physical debilitating conditions or side effects of cancer treatment. Usually, as I mentioned earlier also, that in the cancer treatment nowadays, an interdisciplinary approach has to be maintained for the sake of good quality of life of patients. Only one side of the medical team is not in a position to undertake complete successful treatment of cancer. Now, that is why physical therapy is an indispensable part of cancer management team. So what are the individual based physiotherapy goals? So this is in terminology I have put. For example, a professional driver who has lost his mobility due to radiation induced fibrosis of neck muscles, he will very much definitely want to gain his flexibility of the neck for sideways movement during his driving, isn't it? And another example is a carpenter. Carpenter may wish to restore his ability to hold his arm up for a long period of time. Why? So that he could not have any pain in case of spinal accessory nerve palsy in such cases. In head and neck cancer cases, and the treatment, the resective surgeries which are undertaken sometimes leads to spinal accessory nerve palsy as well. Now, coming to the topic which is ours, that is trismus. Definitely a patient could benefit from jaw opening exercises to help mitigate trismus. And as mentioned in a repeated sentence, severe trismus could limit one's ability to eat by mouth or even get routine dental care. Now, there's a controversial term, that is pre-rehabilitation. To date, it is still controversial. This is actually an idea whether such cases, that cancer patients should be seen by physical therapists before their treatment is undertaken. Although it is still controversial, and if any such assessment is taken, what will it involve? Definitely, it will involve baseline functional assessment of the neck and shoulder, overall strength, mouth opening, and including any deviation and or TMJ involvement. So where does the issue arise? The problem actually with such cases to be seen by a physical therapist before their treatment for cancer is initiated arises that these people are already under tremendous psychological pressure. So the researchers say if we put them under physical rehabilitation before their treatment is initiated, it might add on to added stress which they are facing, not only them, including their families. And we should not forget it that most of the patients who seek treatment for cancer have to go far away from their homes to take treatments for this cancer, whichever cancer it will be. So what else? So in addition, the patient, the head and neck cancer patient or any cancer patient for that matter, is already overwhelmed with visits to other providers, routine diagnostic tests, routine diagnostic tests, other departments, biopsies. So they are already overwhelmed. So that is why this factor, whether pre-rehabilitation should be included in such particular cases, has always been in controversy. But there is always a chance that such patients wherein we perceive that it might be a candidate for potential development of trismus, so such cases might be paid an informed visit by physical therapists and informed about what all future treatment might involve in such particular cases. Now, what are the causes when it comes to the cancer now? As sir has given you the generalized idea about all the etiologies. So let's concise it to the cancer. When it comes to the cancer, the tumor may invade temporomandibular joint, it may invade neighboring muscles, or the fibrosis of muscles might take place after surgical therapy or after radiation therapy. So these are the factors which might lead to trismus in case of head and neck oral cancer. So it is very important to delineate what involves in radiotherapy-induced trismus from other types. As I mentioned earlier also, that whenever we are dealing with trismus, we should know the differential diagnosis, what actually has triggered this trismus. Until and unless it is known, the root cause of the problem will not be addressed. So it is important to delineate, for that matter, radiotherapy-induced trismus, as its management is significantly intense as compared to other etiologies of trismus. Now, when we are speaking about treating this radiation-induced trismus effectively, again, I repeat, this is a repeat statement that understanding and its pathogenesis is very important. So what happens by this radiotherapy? It causes a localized inflammatory response, and that in turn triggers a cascade of events which will ultimately lead to the deposition of collagen, and also local circulation gets obstructed with an eventual scar formation. That is what actually underlines the basic pathogenesis in radiation-induced trismus. Now, it has also been seen to be upregulated. There is an upregulation of transforming growth factor, beta-1, which also adds to this pathogenesis factors, which I have mentioned in the second sentence. Now, radiation-induced trismus, although it is multifactorial, but quite a number of times when MRI of such patients have been taken, it has been seen that most patients have definitely fibrotic changes within masticatory muscles. Now, what is the prevalence of this radiation-induced trismus? It is variable. Different researchers, different literature shows a different range of radiation-induced trismus. I have put this, the maximum one which I could get from the literature, that is 6% to 86% of patients having received radiotherapy to the temporomandibular joint or the masseter or other masticatory muscles with a frequency that is severe and which is very unpredictable. And unpredictable in the sense, it might be based on the population, it might be based on the treatment instituted, it might be based on other factors which were instituted or which were undertaken during the pre-operative or pre-radiotherapy assessment of particular patients. Now, what does this do? This scarring which has occurred because of radiotherapy, when scarring occurs, the loss of function and definitely the mandibular range of motion is going to be affected. Studies have demonstrated that abnormal proliferation of fibroblasts is an important initial event which occurs in these reactions, that is radiation-induced trismus. Now, on top of that, the scarring can also occur because of surgery which has been taken or nerve damage. So what is working here? The combination of factors. It could be radiation-induced, it could be scar because of the radiation. Sometimes radical surgeries have to be undertaken in case of head and neck surgery, nerve damage, or combination of these factors that could ultimately lead to the trismus, which will have a part of radiation, which will have a part of surgery, and which will have a part of the radical surgical procedure, which always keeps the neighboring vital structures at risk. So now, regardless of the immediate cause, mandibular hypomobility will ultimately result in both muscle and TMJ degeneration, because hypomobility of both the muscles and TMJ degeneration definitely adds on to the disuse. Now, this is what I meant actually. Studies have proven that muscles that fail to move through their range of motion for as little as 3 days begin to show signs of atrophy. So joints, in a similar fashion, when they get immobilized, what happens to them? The synovial fluid will get thickened and there will be the thinness of cartilage. Now, patients who have previously been irradiated, suppose a patient has a recurrence and previously has been irradiated and again has to go for radiotherapy, those patients have seen to be at more risk of trismus than those patients which are being seen for the first time for head and neck cancer. Here it proves that radiation has a cumulative effect. So it can work, it can have its effect over the period of years. It's not necessary that a patient has undergone some kind of radiation 6 years back and today we are treating him for recurrence. The previous radiotherapy can have still its effects on the patient now. This is what is termed as cumulative effect of radiotherapy. So when does these trismus manifestations occur in such cases? It has been seen that it takes 4 to 12 months after radiation therapy, and it progresses rapidly in the first 9 months, and it persists for years altogether. So a patient might face this kind of trismus he might have to face trismus all his life, depending upon this the various treatment modalities that were instituted or that were used for that particular patient. Now, I'll brush up again about the consequences of trismus, although discussed by Sir earlier. Now, what can this limited mouth opening result? Before that, I would like to clear one fact that all limited mouth openings actually in literature are not considered as trismus. Trismus, you word is basically solely used for muscular spasm, that is muscles of mastication. And whenever there is some other cause which causes trismus, it has been put in literature as reduced mouth opening. And the cause could be anything. So what does it do? There is reduced intake of nutrition, and in fact, that indirectly will result in weight loss and nutritional deficits. Patient is already facing the dilemma, he is already facing the consequences of surgical procedure if undertaken for such case. Now adding on it, the patient is unable to eat properly. What it will lead to? It will lead to weight loss. It has been seen that a weight loss of more than 10% has a significant effect on quality of life of such patients. What else it can lead to? Compromised airway clearance because of compromised mastication. Normally, a person with a full-fledged normal swallowing function, what does he do? He takes food, he manipulates the bolus becomes a cohesive unit, and then deglutition occurs, it is swallowed. So in this particular case, when you have a compromised mastication, there is always a tendency that some kind of food remains there as a residue in the oral cavity. And that in turn can have the risk of causing aspiration anytime. Now, compromised oral hygiene, as is evident, you are unable to take routine dental cleaning procedures because of limited mouth opening. Definitely, there will be more chances of dental caries, infection, and when such things occur, dental caries occurs, infection occurs. So this limited mouth opening is an hindrance for future treatment of such cases, which this particular case has on top of facing from trismus and the surgery which has been undertaken for his head and neck cancer, whatever. Now, definitely when mouth opening is reduced, it is a common sense that definitely there will be difficulty in speech and swallowing. So these patients, depending upon the degree, they have a tendency to become alienated from social life as well. So as I mentioned earlier, it is a repeat statement again, degenerative changes in the TMJ may occur because of joint immobilization, which is called as disuse atrophy. Now, trismus is not only a painful condition, but it also affects individuals' quality of life, as a lot of cases, lot of studies have been done wherein they have assessed various questionnaires about trying to see how and to what extent this trismus affects the quality of life. So it is very crucial to take measures both pre and post surgery to avoid acquiring the condition and prevent the severity and frequency of it. So when a patient has been assigned for a surgery, actually the preventive measures should start at that particular time. So what are the main ways the physical exercises might be of any help for such potential cases? Simple, I have put: massage your jaw muscles, exercise your jaw muscles, keep good posture, and keep good oral hygiene. This was one of the study conducted wherein self-explanatory exercises were given to the patients, although it did not lead to a significant increase in the mouth opening of the trismus these patients were having, but it definitely could differentiate the patients who were allotted to the exercise group. They had better quality of life, and as well as they could open their mouths to a better extent than those groups of trismus where these exercises were not advocated. Now, these are the appliances which are usually used in case of trismus and radiotherapy, although these can be used for other purposes, other trismus causes as well, depending upon the situation. The first one, this is a therabite, wherein the patient has to apply the torque on the handle. This is used, and literature has given, in a number of studies, they have shown a significant result, but the matter comes to the follow-up. For how long these patients were followed. That is one of the discrepancy which is in the studies. Such patients and the maximum were followed for 32 months. As I mentioned earlier, trismus when occurs, it has a tendency to grow slowly, and it has been seen every month without instituting or without starting any treatment. It grows at a percentage of 2.4% every month, followed by radiotherapy. So this, the first one, therabite, which depends on patient's manual dexterity. That means he has to apply force. It is a useful appliance for patients with sustained trismus, particularly for those who have undergone treatments for head and neck cancers. The second one below is a dynasplint, where patient incrementally increases the torque by just moving a handle. So the first one, the patient has to squeeze the handle. It depends on the patient's manual dexterity. And the second one is just at the brush of the handle. Here is one difference which lies between the two. The patients who are also advocated for adjuvant chemotherapy have been shown that they have a tendency to suffer from neuropathy, peripheral neuropathy. So their manual dexterity might get compromised. So if we compare such cases, then dynasplint has an edge over therabite in those particular cases. Although both of them, some studies have shown that both of them result in significant increase in mouth openings. Although there are definitely some studies, we should not hide away from these facts. There are definitely some studies which have shown no significant improvement. It's a complex matter actually. It depends that it involves that most of the studies which were undertaken by using these apparatus, they had no control group. So that was one of the drawback why they could not come up to a significant conclusion whether these have an long-lasting effects or not. Now these are the studies which have been done by therabite and dynasplint. The first study, this study showed an increase of 7.2 millimeters after 3 months. And there was also increase in quality of life. The dynasplint, a study conducted in 2010, this showed an increase of 11 millimeters of improvement in maximum incisal distance with a regime that was followed for 3 months. Similarly, another randomized control trial, which was conducted way back in '93, it assigned patients in 3 groups: unassisted exercise group, radiation. After radiation, there was no assistance. They were taught how to do the exercises. The second group was tongue depressors, who were using tongue depressors, and the third one, therabite. So they came to a statistical significance wherein they have put by how far, by how many millimeters, the mouth opening increased in respective groups. Now, this study I wanted to mention here is 2011 that showed a decrease in this interincisal distance in both intervention and control group. The decrease was, but this is a very important point, the decrease was less in the intervention group, which implies that any kind of exercise therapy definitely has a positive role in such situations. This is another homemade and very counterproductive, very cheap, that is tongue blades, which also can be initiated or which also can be used by such cases. As I have shown in the previous study that the tongue depressors, they showed around 6 millimeters of opening, increase in opening. Now, what happens here, when it can be beneficial also, for the two apparatus earlier, the two, which I mentioned earlier, the therabite and dynasplint, they need at least a mouth opening of around 9 millimeters to be effective. If a patient has lower than 9 millimeters of mouth opening, these two apparatus, these two machines are outruled in those particular cases. So for such cases, there is a probability that they will be given advice to use tongue depressors to begin with, and when they have a little bit of improvement in their, obviously if it occurs, they have an improvement, then in that particular case, then they can be shifted to the terabyte or dynasplint in future. Now, how far has been the acceptability of intervention, that is physical therapy or exercise therapy, in case of patients who have had radiation-induced side effects? This was a study conducted wherein the patients, most of the patients could not tolerate these exercise interventions. Why? Because of immense side effects the radiation therapy has initially, in the form of ulcers, widespread ulcers, painful mouth opening. The ulcers can be found anywhere in the oral cavity. So as these patients were interviewed during their treatment as well, what actually deterred them if they have stopped this kind of treatment, which was initiated, which was given to them, that is physiotherapy intervention, by use of either exercises, jaw exercises, mouth exercises, or therabite or dynasplin. So what actually deterred them? So this was the main, by most of the patients who were recruited for these studies, that they could not bear with the immense side effects the radiation therapy has created in the form of blisters, oral ulcers, painful mouth openings, so many. As one patient has put it, that I didn't want to think about it, I just wanted to get on with my life. That is one of the patient's interview, and he was asked, what happened to your exercise regime? That is in the last paragraph, which he has put, that he just wanted to go on with his life and he wanted to forget about all the exercises that were leading to the unpleasant time that already patient was facing because of the radiation effects. Now, coming to the acceptability of intervention when treatment side effects were abating, yeah, most of them showed a positive approach. They said, yes, definitely helped me to increase the opening size of my mouth, and it actually did improve flexibility for me to open my mouth, definitely. Did exercises more than 5 times a day, more often as I could see the benefits. I only took the break during radiotherapy. That is the previous slide which I mentioned earlier, because of radiation side effects. One more important point we have to evaluate is family support. As during our undergraduation days and post-graduation days, during the taking of case history, there is a column about family history. Why is it important? It is important for many aspects. Sometimes we tend to assess the patient for a disease and we want to see whether this disease is inheritable, whether this disease has come from his forefathers. That is one of the important factors which we utilize and which we evaluate during case history taking from the patients. Although during our student times, we try to undermine these factors. Now, this is what a patient has mentioned in his interview, that this is not only to see the inheritable diseases when we are assessing the family history, it is very helpful in cases of chronic illnesses as well. When a patient comes with a chronic illness and the treatment of the patient, there is every chance that the treatment of the patient has to be prolonged. That is when this family history is very important. We want to see what kind of support this patient is going to have from his family. Now, this is what a particular patient has put. Although it was difficult time mentally to go for the exercises and physiotherapy interventions, which I was advocated, and psychologically also it was depressing, but I'm very positive person and my wife is amazing. This is the point wherein family support takes a very vital role in such illnesses. Now, we have to set goals actually when we are treating such cases in an interdisciplinary approach. How to set these goals? Now, when patients have reached their maximum potential interincisal distance improvement because of post-radiotherapy and because of physiotherapy interventions, which can be of any part, either by exercises or these interventions, therabite, dynasplint, or even drugs. There are drugs also which have been, there are studies in head and neck cancer patients, not only physiotherapy, even drugs have been studied whether they will result in increased mouth opening. So when an increased opening mouth occurs, what happens? The patients are discharged. Now, from that point onwards, it is the duty of those patients to comply with the continuous physical therapy exercises. Otherwise, it is always going to recur. The length of physical therapy course will be influenced by several factors, which include the patient goals. I will give you a couple of examples. Suppose a patient who has a potential to lose proper swallowing function in future because of surgical approach or because of radiotherapy, there is no need of gaining mouth opening in that particular case more than 35 millimeters. Because if the swallowing, chewing, masticatory functions are already undermined, so such cases will suffice by a limited mouth opening of over 20 millimeters or more to maintain routine oral hygiene. These factors have to be assessed. On the contrary, when a patient with full-fledged masticatory control, the mastication and the swallowing function, if that particular patient is unable to gain mouth opening, such kind of, irrespective of treatments instituted, irrespective of treatments that are advocated, continuous physiotherapy, even on top of that, if he is unable to gain the mouth opening, definitely he has to rely upon the soft diet or cutting the food, that is pre-eating manipulation. So he has to cut the food in small boluses, small pieces before he can take the food. So these are the goals which comes into play when an interdisciplinary team sits for identifying such cases and going through the potential future. How far these patients will or in a position to gain by whatever treatment modalities are advocated or given for such cases. Now, when all fails, there have been a number of studies that have been undertaken that coronoid process resection is undertaken in such cases. There was a study performed on more than 15 cases, and it was seen that mean incisal distance improved by 22.1 millimeter and 21.8 millimeter at 6 and 12 months respectively. The coronoid process was resected, the temporal muscle dissected, and as a result, they gained mouth opening. But again, it boils down to the point how far these patients were followed or will be followed in clinical practice. That is very, very important. So all patients maintaining an interincisal distance. This is unrelated to the head and neck cancer, but I wanted to share this case. This is the reduced mouth opening. We won't be able to call it trismus, as there is, as I mentioned, that controversy in the literature. So this is a reduced mouth opening around in 15-year-old boy. And upon assessing the various diagnostic features, a scan was taken after ruling out any infection or any local factors which could have led to this reduced mouth opening. So ultimately a scan was taken, and it was seen that the coronoid process of the mandible was, there was hyperplasia of coronoid mandibular, coronoid process. And upon opening, this coronoid process was impinging on the medial surface of the zygomatic bone. The patient had around 15 millimeters of opening when the patient approached for the treatment. So after resection of coronoid process, bilateral coronoid process resection was done, patient gained immediately a mouth opening, and it went beyond 25 millimeters. Of course, physical therapy doesn't stop before this. Once these patients are undertaken for surgical procedures and surgical procedures are done, definitely they have to be kept on physical therapy again in order to see that no more recurrence or no more fibrosis of the muscles occurs, because any kind of manipulation in the oral cavity might lead to fibrosis in future. This is my own case. This is our own particular case. This was a 16-year-old female patient who reported to us with a normal mouth opening. The mouth opening was good. As far as I remember, it was 43 millimeters. She had a slight deformity on the left side of the face, and we could not assess clinically what actually is leading to this deformity in the face. So again, we undertook one scan, And as you can see in the first A top, the left coronoid process, it is hyperplasia. It was an osteochondroma. So it is hyperplasia has occurred, and it is almost impinging on the medial surface of zygomatic arch. And the zygomatic bone has remodeled itself. As you can compare it on the right side, it has remodeled itself over the period of time. I repeat, the patient had no problem with mouth opening as far as we assessed, because it was 43 millimeters mouth opening. The patient was tall, 16-year-old girl. And upon what actually we did then, this is the another 3D reconstruction. You can see this left coronoid, this is the right coronoid process, the usual normal, and the left coronoid process, which is almost going to the medial surface of the zygomatic bone. So we resected this coronoid process, the left coronoid process we resected, and we evaluated patient after 3 months and after 6 months as well. What we came to know, after 6 months, the patient's mouth opening was 47 millimeters. So there could be a lot of reasons for that. The first reason, the first measurement could have been error, which we did pre-surgical 6 months back. That could have been because of an error, 43 millimeters. Another reason is that, was this definitely impinging with somewhere and the patient's mouth opening was compromised? It was more than 43 kilometers. But we could not assess that because we had not taken a scan in the open mouth position, as is shown in this previous case. When you take a scan in open mouth position, you can see the final position of the coronoid process as well, how far it is impinging on the coronoid process. So we could not judge that, and unfortunately we lost the patient follow-up as she shifted to some other place for some studies purposes. Anyways, I wanted to share this case. And this is one more interesting case which I came across. This is post-extraction trismus, although not related to my talk. But this patient was shown in this publication that definitely the patient, this cloth peg, this definitely helped the patient's mouth opening to increase from, as we can see in the first picture, before it is around 16 or 17. And over the period of a few weeks, it was beyond 32 millimeters. So the patient was given this and was asked to use this exercise for 2 hours every day. And after 2 weeks or 3 weeks, I don't remember, the follow-up, the patient's mouth opening was increased. I tried doing this at home with my cloth peg, which I had, but unfortunately that cloth peg didn't have much torque. That means when the patient is showing here around 15 millimeters, it should increase more than that. Or for that matter, maybe they have put this clip on the posterior region between the molars. That could also be some reason for that. So to conclude, considering high prevalence of trismus in published studies and the quality of life deficits, as I mentioned, a lot of questionnaires have been tried and deficits have been seen. So increased efforts for patient education, prevention, and early treatment options are warranted. So that definitely comes to the point that we further need large prospective trials, and wherein definitely one of the points which I would include is that group should be there, that is control group, and the follow-up period should be modified, as most of the studies could not prove that for how long they had followed such particular patients. One more point I would like to add here, we have to confirm and we have to see whether intensely modulated radiotherapy will be of any help. For those people who are not aware of it, it's a radiotherapy modality wherein the radiotherapy is focused and there is the strength of the beam is inhomogeneous. So wherever we need the particular dose, this will have a particular dose at that particular place, and leaving aside, sparing aside the other vital structures in the neighborhood. So this also has to be followed, whether this will be of any help in reducing radiation-induced trismus. And quality of life and economic part of this common oral sequelae of radiotherapy also has to be assessed. With that, I end this presentation. Thank you, and thank you very much for your support.
Thank you so much. I thank Oral Medicine and Radiology Department, Dental College, deemed to be university for their wonderful presentation. Before we go for the question session, we are pleased and honored to have Honorable Pro Vice Chancellor, deemed to be university, Dr. Shripati Rao, sir, today with us. I welcome you, sir. Thank you for joining us, sir.
Thank you so much. I was not able to participate in the beginning where there was a Vice Chancellor meet, but I heard the second part of the presentation. Dr. Sajid is a postgraduate?
Sir, I request Dr. Shripati Rao, sir, to speak few words and enlighten us for this webinar, sir. I request you to speak few words, sir.
Yeah. Dr. Mudassir, who is the
Yes.
person present at the end? He is a postgraduate?
Dr. Sajad is a faculty from Oral Medicine Radiology and is a PhD scholar as well, sir.
Okay. You are all right. I understand. Excellent presentation.
Yeah,
I should
please,
say that he presented very well. I just want to clarify one thing. Because he basically spoke about the effect of radiation and leading to difficulty in opening the mouth. Actually, the word Trismus should not be used in cases of radiation because it is not only going to affect the muscles, it's also going to affect the juxta epithelial hyalinization or fibrosis. So, in total, there is a fibrosis of not only the muscle, even the soft tissues which cover the oral cavity. That's why it is very difficult to treat a case of difficulty in opening the mouth in radiation. Because just releasing the muscle or just treating the muscle mechanically is not going to help at all. So the improvement is not that much in case of post radiation unless you started the treatment very early following the radiation. But when you say trismus purely, as he pointed out very clearly, it is difficulty in opening the mouth due to spasm of the only masticatory muscles. And commonly, this term is used when it is affected by infection, trauma, or other causes. But post radiation, I don't like to use the word trismus. It is the reduced mouth opening or difficulty in opening the mouth due to various reasons, a layer. That's the reason it is very severe in case of radiation. This point I wanted to highlight. Thank you so much.
Thank you, sir.
thank you so much,
Hello?
sir.
Yeah.
Yeah, thank you so much, sir, for your wonderful words and to enlighten us and to join us, sir. I am very thankful to you, sir. Now
Thank you so
I'll
much.
hand over. Thank you, sir. I'll hand over to Dr. Varsha, the moderator of this session, for question answer session. Over to you, Dr. Varsha.
Good afternoon. We had three questions from the audience. The first question is, kindly enlighten us regarding the collaboration in research and practice in dental or oral conditions between physiotherapy and the dental profession. This was asked by Nigel Gonzalez.
Yeah, this is Dr. Chatra. There are enormous scope for the research in this area, especially the precancerous conditions like oral sulcus fibrosis, wherein the fibrosis of the tissues taking place, there is no trismus of the muscle as such, but there is a restricted mouth opening. In these cases, especially the stage 3 and the stage 4 cases, we require either surgical intervention or post-surgical intervention, we require a physiotherapy. In this area, a lot of studies have been done, not in terms in dental as such, but not in the physiotherapy area. I think there's enough scope in these areas. And the second one is the anterior disc displacement with reduction and without reduction, where yes, that's it.
Thank you, sir. There's another question from Dinesh. When do you refer for physiotherapy in case of emergency? When a patient first shows to physiotherapy, what can be done? Like when the patient first reports to physiotherapy department, in case of an emergency, what needs to be done?
The ideal management of the any disorder in case of an emergency is to underline disorder and symptom has to be subsided the first. It's not the treatment modalities taken care in the first. If, for example, patient come with an anaphylactic shock with a trismus, he cannot be sent for a trismus for the physiotherapy first. Yes, underlying cause has to be eliminated. The first direction is always eliminating the underlying cause. If you can able to find out, then you go in for the surgical option or a physiotherapy option.
Thank you, sir. We have another question by Shalima, Dr. Shalima from physiotherapy. She asked whether dental trismus is temporary or permanent.
There is nothing like a permanent trismus such. It is always called as a temporary and the persistent. If a trismus is last more than 15 days time, it is called as a persistent trismus. We need to look in for an underlying cause for it and go in for the treatment. For example, there is a third molar impaction, wisdom tooth impaction. It's not coming out on the time. It may cause an injury to the patient and followed up by the trismus, spasm of the muscle leading to restricted motor. That may last more than 15 days because patient is not consulted a dentist at that time. It won't call it as a permanent. Once you remove the etiology by removing the tooth of that area, within 15 days time it will come back to normal. It's nothing like permanent. There are certain cases where, like in an ankylosis, bony ankylosis of the patient, at that time, again, if the patient is not shown to a dentist or an oral and maxillofacial surgeon, it may be permanent for him. If you show it to a person, it can be reducible. Yes.
Thank you, sir. There's a question by Vandana. She asks, when we use a jaw opener for trismus in carcinoma of the head and neck, where actually does it have to be kept? Does it have to be kept centrally between the teeth on the anterior aspect, or does it have to be kept at the side of the surgery unilaterally?
Yeah, the actually these jaw opening devices which I showed here, they have got nice platforms, just like we have dental trays. You can, it is quite evident from the picture. It covers backs we have, that whether such apparatus can be used in edentulous cases. So no, we cannot use. As far as its dentulous dentate patients is concerned, they have got occlusal tables. They are situated, they are suited according to the shape of the jaws. So both upper and lower tables, there are two tables for upper teeth and two tables for lower teeth, and they cover at least 8 to 10 teeth, both upper and lower. So platform is made already. Dynasplint, on the other hand, which I showed, sometimes what happens, it has to be custom made. That is the answer for the question. So the assessment of the oral cavity is done, and it is seen that where all the support can be taken.
Hello.
So we have to see, that is why in case of undermined jaws, they are not advised to use. They are not for as placement. They have got nice occlusal tables. It is placed and it covers 8 to 10 teeth in the both upper as well as the lower jaw. I hope I answered the question.
Hello. Can I come?
Yes, sir.
Yeah. See, I would like to answer this question. Now, what he has shown, Sajid has shown, these splints are not available in our country. As you all know that we don't use this frequently for trismus. What we have basically is a Ferguson's mouth gag, or we use the spoons, the wooden spoons we use for opening the mouth. When you use these two things, ideally it should be applied bilaterally in the molar region, multi-rooted teeth. Otherwise, you might knock out the front teeth. So it should be applied near the molar region and bilaterally you should apply. Then only there will be uniform pressure and it will try to open up. If you do unilaterally, there's a possibility that you might damage the TM joint on the other side. That's one thing. There is a question asked in the some physiotherapists asked, is there any role for a physiotherapist in the management of trismus? Absolutely yes. There are two situations. If the trismus is following the infection, immediately they don't have a role in the initial stage because the infection has to be controlled. Only then, if the patient has trismus, they will apply whatever the device they want. Either they can give a heat treatment or they can give ultrasound, all that they can do it. But in case of trauma, if the patient gets following the surgery or following the trauma, if they get trismus, that is due to inflammation. There they play a major role in the initial stage to control the inflammation and to relieve the pain. Because when there is a pain, you can't use any mechanical devices because that will increase the trismus. That's where the physiotherapist should apply their treatment protocols and reduce the inflammation and then go for the mechanical aids. Thank you.
Thank you, sir. There is another question from Nigel Gonzalez. Do diabetic individuals have an altered response to dental pain? Dr. Chatra, sir?
Yeah. There is a less amount of sensitivity to pain in the diabetic patient in a long run, depending upon the sugar levels. On the sustained sugar level for more than 3 weeks' time in that particular higher level may have the underreaction to the pain. Patient may not have any pain as such, especially when they come over. It's a reduced amount of pain. Definitely it will be there.
Thank you, sir.
Thank you.
I hand over to Dr. Mudassir, the coordinator of the webinar series.
Thank you, Dr. Vandana. I request our principal, Yenapoya Physiotherapy College, Professor S. Padmakumar, sir, to conclude the session. Over to you, sir.
Good afternoon. Good afternoon, Professor Ansel sir. Good afternoon to Dr. Chaitra and Dr. Sajad for the wonderful presentation. Thank for all the participants for joining and staying for about 2 hours in the session. It was an elaborate session, useful for the dentist and the physiotherapist both together. It was very informative, and hope all the participants have enjoyed the talk and got the messages what they expected to, and hope the questions were made answerable to them. And thank you all for joining with us for this webinar series. And tomorrow we have 2 more webinar, and we are concluding that webinar series by tomorrow. Once again, thank our Vice Chancellor sir for joining and giving us his valuable comments.
Thank you so much.
Thank you, sir. And thanks, Dr. Chatra and Sajad for the wonderful presentation. Thanks, Mudassir.
Thank you.
Thank you for giving us the chance, sir. Thank you very much.
Yeah,
Thank you for giving us the chance.
And
I once again thank our Pro Vice Chancellor, Dr. Shripati Rao sir, for joining us. As sir was busy in the meeting morning, he could not join us. I'm highly obliged for you, sir, for joining us for this session. I cordially thank Oral Medicine Department, Vice Principal of Yenapoya Dental College, Dr. Lakshmikant Chatra sir, and the faculty of Oral Medicine Radiology and PhD scholar, Dr. Sajad Bas, for their wonderful presentation. As trismus is a really condition where we can work as a multidisciplinary team to benefit the patient. So it was a wonderful talk, and I'm very sure that all the participants gained insights out of this presentation. And I'm sure, like, for the betterment of our patient, we can work together and we can work as a multidisciplinary team. Thank you all for your presentation. I request the participants, if you have any further questions regarding the topic, you are kindly mail us. We will get back to you with the positive feedbacks. I once again thank you all for joining us. Have a good day. Thank you all.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you, sir, for a grateful topic.